For our second session on vision, we're going to move to more of a global picture, and I think some of the future issues and future ways to care for our vision. Our next speaker will be Dr. Shen. She is the Lyons Assistant Professor of Ophthalmology, and she also has an adjunct appointment in bioengineering. She is the director of Refractive Surgery Center here. And in addition to specializing in refractive surgery, she is interested in medical and surgical management of corneal disorders and cataract surgery. Her academic pedigree is very impressive. She received her medical degree at Harvard and then her doctorate at MIT, and this was in medical engineering and chemistry. And I think you'll see that this is a wonderful combination when you think about what she is working on. She was the first recipient of an award here that's called the Emerging Inventor of the Year. And she shared this with Dr. Parviz. And what they received this for was something that they developed, which is, it's an active contact lens, and it can wirelessly communicate important information about the health of the eye, and I guess the whole patient. And I'm hoping she'll tell us a little bit more about this. She has a few other patents through the UW Technology Center. One of them has to do with a controlled drug delivery for cataract surgery, and the second has to do with developing a prototype for an artificial cornea that can be used to treat blindness globally. She is very active volunteering her services. She received the MLK Award for Outstanding Community Service in 2006. And she volunteers internationally. She will fly to the People's Republic of China or Inner Mongolia and have a very intense experience of seeing patients, doing surgery, and teaching. She's also passionate about a few other things, and one of them is art and beauty. She actually paints, and these are some watercolors that she has painted, and I think ophthalmologists, they appreciate beauty. This is another one of her pieces. And just notice the symmetry and the colors. Now, as a scientist, they have to be orderly and detailed. This is some more of her work. She does calligraphy, and she tells me that the left one represents spring, and the one on the right, with the red background, is good luck. She is, in summary, amazingly talented, a phenomenal background. She's a calligrapher, an artist, a clinician, and a scientist who is doing some very innovative work. I'm supposed to warn you that some of this will be graphic, and she's going to warn you before she does show them. Let me just pull up her slides. So join me in welcoming Dr. Shen.
Thank you very much, Dr. Elmore, for that wonderful introduction, and good evening. I'm really excited to have the opportunity today to share with you some of the clinical care as well as research that's been conducted in our department and our medical school. I think for me, it's a very personal journey in terms of treating blindness. And I'd like to use this opportunity to share with you tonight the really wonderful technology that's helped us to help our patients and the opportunities and challenges for global blindness that we still face today. And for many other fields, I think ophthalmologists are, I call myself nerds in the sense I love technology, I love gadgets, and we're very, very quick in embracing innovative technology and quickly translate those research and innovation to our patient care. Even within my short period of career in ophthalmology, I've witnessed a lot of improvements in the quality of care for our patients. And today, I'd like to share some of that with you. In the following 40 minutes or so, I'd like to share with you 2 of those conditions that's treatable and what we do in this country that we're very lucky to be able to treat those patients and what challenges we still face in the global market where many of the patients still need care. And finally, I think that this hour I'd like to share with you some of the interesting research we do to give you a glimpse of what future might bring and ask you to join me to imagine those possibilities in the future. And I understand some of the audience may be sensitive to eye diseases and pathology. I'll try my best to warn you before some of the graphic pictures show up. But I noticed that you already had the handout, so you might be a little desensitized at this point. So this is a picture of artificial cornea, a program we started here in the University of Washington in 2004. And the talk that I'm going to talk about really is development of materials and technologies and how do we use that to help people around the world. I'd like to start with sharing a personal story with you. This is a story that a gentleman I met, a young guy, who was brought to me in one of my trips with Orbis International to rural China. His mother brought him over here. At that time, he had been injured for a couple of years, and both eyes been burned with alkaline. And this is what his eye looked like, and I apologize for not warning you ahead of time. So the cornea is really scarred because of a chemical injury, and he has that in both eyes. At this point until then, a 23-year-old man with bilateral blindness of the cornea, which is the window, it's really true, still a sentence to blindness for life in most of the people in those regions of the world. Unfortunately, his story is not really quite alone. Every 5 seconds in this world, a person goes blind, and that statistics is going to increase. As we can see here, from 1990, that number is 38 million, and quickly by 2020, that number will double. And for all of us who dealt with people who was vision repaired and blind, or you have family members, you always know blindness is never an isolated problem. It's causing burdens to not only the individual who's visually impaired, but affect their family, affect their communities, affect their society. And one of the groundbreaking research is done by actually Professor Christopher Murray here, is to define a parameter to measure the burden of disease. And this is being widely used to measure how much disease is causing the society, not just for the prevalence, but for the impact for socioeconomic reasons. And if you look at the latest data for these studies by 2030, we notice a vision-related impairment, such as cataract here, will rise from ranking number 14 to top 10, surpassing TB and malaria. So that gives us an idea how important vision is to every one of us who has the privilege of using our vision, but how much impairment that is for people who's involved in that. Look in the world, we look at the map of distribution of blindness, and the darker the color, the higher the prevalence of vision impairment. You notice, sadly, 90% of the people who's blind actually live in the developing countries. And even more concerning is that 75% of them actually have blindness that's treatable. Take corneal blindness as an example. There are 12 million people with corneal blindness in this world. Less than 1% are treated today, although the surgical treatment for corneal blindness has been available for more than a century. So why such discrepancy? I think a lot of it relates to the infrastructure that's available in the developing countries are not quite as good as we have. For example, hospitals, clinics, pharmacies. In the cornea blindness issue, that donor cornea tissue is really hard to come by in the developing world. There are infrastructure efforts. For instance, this is one of the moving vans that can drive in the countryside to do surgery. But a lot of other limitations to access care and follow-up care, for example, will still make delivering those surgeries impossible. Finally, because of the lack of healthcare in developing countries, a lot of the disease are left to be very severe forms, and the surgery that we use here in this country will be not applicable. Because of those reasons, we believe that we need to leverage science and technology and try to do what we do, but better for the developing countries. We cannot just try to do what our current technology, but cheaper. Sometimes, because of lack of infrastructure, we cannot deliver as good of an outcome in the developing world. So we need to really work as a group, and also the awareness, like audience and who you are, sitting in the audience here, thinking about how to help and to raise that awareness is really important. So for today, I'd like to share with you really 3 examples. 2 of them, as Dr. Elmore had mentioned earlier, is to use our technology and leverage our research, then to target specifically to the developing countries, which results will also benefit our own care. And finally, I'd like to share with you some of the earlier prototypes and maybe outlook for the future, what we can do for global medicine. So the eye as optic system, for tonight, I'd like to focus on 2 areas that cause blindness. One is the cornea. As you can see here, if you have a corneal scar, then your view is blocked because the window is opacified. And then the other one is the lens, how to treat cataracts in the developing world. So first one, we looked at drug delivery for cataract surgery. Why is that important? So let's first take a brief look at this. After removal of the lens, we need to put an intraocular lens in the eye so that we can restore the focus of the eye for a patient. And we'd like you to focus on the intraocular lens implant itself. And if you look at the intraocular lens implant, they both have 2 haptics to keep the lens inside the capsular bag. And of course, you can see the lens was injected into the eye so that patient can have surgery with a small wound so he can have much faster recovery. What we looked at is even though our patients have very excellent results after surgery, so you can see the patients looking around, so their eyes actually just numbed with eye drop. But to deliver such a great outcomes, patients have to use eye drops after surgery. And one of the issues with cataract surgery, of course, just like any other surgeries, we worry about infection after surgery. For my patients, I feel very lucky to write them a prescription. You can go to pharmacy, get your eye drops filled. But if I go to rural China or other developing countries, there is no pharmacy in the street corner. So what do we do with infection? So these infections could be immediately blinding, and that is one of the major barriers for cataract surgery being done more effectively in those populations. So keeping that in mind, that's where we initially considered how can we help those patients who have no resources to get eye drops. And we used then to look at potential modern materials to use a design as shown here to really give the drops at the time of the surgery. So when you have the intraocular lens implant, that we can embed these medication droplets or tablets so that those patients can be free of medications after surgery and prevent them from getting infection. One of the issues that we wanted to take a look at here, of course, not only these design has to be compatible with current surgery so we can deliver quickly to the patients, they have to be easy to use and also inexpensive so that the global market can afford them. Because right now, a bottle of medicine in this country can cost $80. That will be, a whole village's expense maybe. So that's too expensive to do. So with this in mind, we actually looked at a polymer that could fulfill those requirements. They can be attached easily to the haptics and release drugs in a custom way so we can pick the optimized version to allow them to release medications for about 2 weeks or so. With those, we looked at similar surgery in rabbits model so that we can demonstrate that these can be compatible with modern surgery. As you can see here, if you haven't seen it from the previous surgery, this is actually how the lens injector is loaded even for our regular patients here. So these are standard setups for intraocular surgery. And those are the beads that we developed, these specialized hydrogel molecule that's embedded the antibiotics in there, and that's delivered into the eye, just like what we've shown on the picture. And with that, because it's out of the visual axis, the patient will not see it, but it will stay there to release antibiotics until the recovery of the patient is complete. And we have actually demonstrated in the in vivo model that the antibiotics by topical application, which is shown here in the triangle, and the antibiotics delivered right in the eye have very, very similar outcomes the medication actually lasts as long as 30 days in the eye. So we're excited to see that this technology actually can overcome induced infections in rabbit models and allow the infection to be controlled because the medicine is released inside the eye. This is just an example of when we use simple to use technologies, but it does require quite a bit of research and effort. So we have a very clear goal out front is to we wanted to make sure that everyone who needs this can afford it. So the material actually turned out to be about 10 cents a piece. So there's a company right now interested in using the technology to develop that commercially so that we can help the people in the developing world, as I've shown for you before. So one example of doing that, and the other I wanted to show you now, if you remember, for switching gears a little bit, other than cataract surgery, the other one that's treatable blindness is cornea. The cornea is the window for the eye, and if the cornea has a healthy times, for instance, if you look at people's eyes, if you look at each other, people describe that sparkle in your eye, that's actually the light reflex in your cornea. So normal corneas are transparent. They actually help you to focus light in order to see and also help you to prevent infection from happening to the eye. The next, I will show you some unpleasant pictures of cornea when they're diseased. When cornea is diseased, then you go blind. So this is one of those examples related to either trauma, infection, and also sometimes very severe diseases of the cornea that cause the window to be frosty. So you can imagine trying to look through these opacified windows, you are not going to get very good vision. What do we do with corneal blindness? And actually, corneal transplant surgery has been available for about more than a century. It was originally first performed by Austrian ophthalmologists using a cadaver tissue. And nowadays, what we do is we use a circular blade to remove the damaged cornea, and then we have a donor cornea available to us through the tissue bank. And then we sew literally of the new tissue onto the recipient eye. So if you can look at the picture on your left-hand side, after surgery, you can still appreciate some of the sutures. This is actually one of our patients. These sutures are used to secure the corneal donor tissue, and the patient can see fairly well after surgery. So it's probably one of the most successful transplant surgeries that we have because the cornea is relatively isolated compared to any other organs. And in this country, we're also very privileged to have an eye bank system that allows us to have very high quality tissue available for corneal transplants. For my corneal patients, they can schedule their transplant date based on their schedule. We can always count on a very high quality tissue for them to do. But in the developing countries, that is very difficult to fulfill, and the infrastructure is not there. And also sometimes the cultural inhibition for patients to donate tissue is making corneal transplant very difficult. So severe corneal blindness, what do we do? In this kind of case, is actually similar to the case I showed you in that young man's eye. Regular corneal transplant won't work because you don't have the normal infrastructure on the eye to supply a regular human tissue. In this kind of situation, actually, artificial cornea become very useful. The idea of artificial cornea is very simple. You're trying to restore the clear window of the eye, so they have an optic center, and you have to secure this window somehow to the patient who received the artificial cornea, so it's a supporting plate. And the artificial cornea program we splashed here is actually invented by Dr. Doman, who's one of my mentors at Harvard. And he devised a very simple to use artificial cornea shown here that can restore the central clarity of the window, even in the case of very severe corneal blindness patients. And I'm going to show you how that's done in cartoon version, and I'll show you one that's a real surgery. Okay? So in general, we require corneal tissue from the eye bank so that it can be as a carrier for the artificial device. If you can see here, these are the optics as shown in here. And then you secure the donor tissue along with it. And then the entire construct are really constructed very similar to what you might find in the hardware store. So one of the beauty of being a cornea specialist, I think, is that I could say that if you have a damaged cornea, at least I can restore it one way or the other, whether it's with human tissue or things I can find that's made of plexiglass. Okay. So then you do this surgery similar to as you do corneal transplants to restore the vision. Okay, so for the next one, I'm going to show you how that's actually done in the operating room and how is that done on the human, on our patients here. And if you're not, I understand some people really, when they look at the eye surgery, sometimes you're very curious about it, and some patients actually do feel a little queasy about it. So just want to warn you ahead of time. So this is actually how the artificial cornea is assembled in the operating room. So that's the optics as you've seen it. So we see this, these all come in a sterile package. So we make sure that all components are available. And also I'd like to show you what the donor cornea look like that we get from the eye banks. In the Pacific Northwest, actually, we have very, very generous donors in our region that our eye banks actually the highest, has one of the highest processing tissues. So because of our populations are so generous and donate their tissue to our patients in need. So what we do here is to secure the optics in the operating room table, and then you can see that's a sticky tape. The reason for that is because the optics are very, very slippery because they're very polished, give you a very good vision, but they can be slippery. So that's a donor tissue that's supplied to us from the eye bank. And we cut the donor tissue based on the size of the patient, so that's a circular, one of the circular blades allows you to really cookie cut the donor tissue to the right size. Okay, so you can see that now the tissue is being cut in the right size. And then we wanted to make sure there's a little hole in the middle to accommodate the artificial cornea's optics. So another hole is made in the donor tissue. As you can see here, when you lift it up, there's a little hole there, so we can put the optics through. So these are all assembled in our operating room right before the surgery. So the donor tissues now slip over the optics to make sure it's actually well-centered and secure, because that's what we use to suture the cornea onto the human, onto the recipient. Okay. So we make sure that the back plate now is secured on the back. Okay. So now you can appreciate why I say that everything's you can find in the hardware store. It's really like you're doing a home project. So the back plate now is really tightened so that the optics are securely fastened onto the corneal tissue. Okay, so the special wrench is supplied to accomplish that at this point. And then finally is the locking ring. It's like one of those locking rings you do find in the hardware store. This is made of titanium, so that we'll make sure that all the plates are secured and not to unscrew after surgery. Okay, so that completes the assembly. And the next I'd like to show you is how that's used. So with that in mind, this is our artificial cornea assembled on the side of the table. And then now we pay attention to our patient who has previously, this patient I think 7 grafts. So he had 7 failed transplants. And this one we decided that we'll try, the more you do transplants, the more likely we'll get rejection. So this is a marking pen. So give us an idea where the perspective of the eye is. You can see that the failed graft is right there. So similar circular blade now used, very similar to the cartoons that you've seen just now, allows you to remove the central cornea very precisely. So the cut is actually being made. So I'm zooming in with my microscope. And then now you enter the eye with a sharp blade. So when you enter the eye, there's fluid, so the pressure drops to 0. So you need to work very carefully, very quickly to remove the corneal button. Okay, so that's the hazy cornea that actually is blocking the vision. Okay, so again, very similar circular scissors to use to remove those cornea after the group is being made by the circular blade. Okay, so these are the scissors to left and right to make sure that's precisely removed. Again, for people who doesn't like to look at the surgery, I'll tell you when it's over. It's like my kids, if there's scary movies coming up, they'll say, tell me when it's over. So now the corneal button that's diseased is removed. You can see that there's normal structure underneath it. And then we suture, this is the assembly that you just saw, how the artificial cornea is assembled, and that's just been sutured. These sutures actually are very thin. you may have a little appreciation of where the suture is. It's very, very thin right here, thinner than my hair, although I do have thick hair. But, and these sutures are meant to stay in the eye for at least for a year to secure the cornea in place. You can see that knot's been made. So that's one throw, and then you can come back. So all of that, you do it just like sewing all around to make sure that the tissue is actually secured to the host. Okay, so our assistants to cut the corneal tissue. So you can see how these suturings are done. I won't bore you for a lot of sewing. Usually this takes about 30 to 40 minutes to complete during the operating room for the entire procedure. Once you can appreciate already that once the cornea is sutured right here, the centerpiece, which is a plastic optic that's precisely made actually for that particular patient's eye, allows you to see very well. So that's one of the beauties of the current setup is that you can restore vision actually very, very nicely. Unlike the human tissue, which is soft, sometimes you have to deal with astigmatism after surgery. So this just to show you how the suturing are done. It's one of those incidents actually we train our residents how to suture because that's very important in corneal transplant surgeries. In fact, with this kind of artificial cornea, it's very important for the residents to have their hands to learn how to do it because the outcome of suturing is not as critical because the optics are very well controlled. Okay, so you can see that sutures are replaced all around the corner, so you can see those markings on the cornea at the beginning of the surgery is really to give me a place where the sutures are evenly placed on the eye as we move along. Okay. So as the 4 cardinal sutures are done, you can see that the eye is a lot more formed. This is one of those incidents that I wanted to warn my patients don't cough, because when they cough during the middle of the suturing before the cornea is placed on, there's a lot of danger for losing the content of the eye. But usually our patients are very, very cooperative. They don't cough during that time. So that's the end result. You can see that most of the sutures are placed and the eye is secure. So I'm checking the wound, make sure they don't leak. And usually at this point, the patient can see a little bit, although vision's a little bit blurry, but they can check and see that the cloudiness that was covering the vision is gone. And we place a bandage contact lens on the eye to secure the graft as well as the artificial cornea. So that concludes the surgery. Okay. Fairly straightforward. In this case, for a very for people who have corneal blindness with artificial cornea, the outcomes can be very satisfying, those selected patients. For instance, in this case, that one type of artificial cornea is replaced, the window is clear. The other one, like this patient of mine from Montana, because his injury is so severe, including the eyelids, we use one of the extensions of the artificial cornea to give him that window. And he actually would cosmetically appear to be this way. So he has a window, though he doesn't need to blink because the window doesn't need to be clean like normal tissue. And he actually is one-eye patient, active. He has 20/20 vision and golf and drive. So the only thing he wears shaded glasses because of cosmetic reasons. But at least for him, the choice of seeing and functioning versus cosmetics, the choice is very clear for him. And just sort of upgrade for the patient that I showed you earlier, and we actually did the first artificial cornea in China using their facilities. So it really demonstrates the importance of we're able to transfer the skills to the less than optimal operating conditions in developing countries. And he actually, within the first week, is able to see enough and his vision's good enough to drive. And other than burdening his parents, he actually now talking about finding a job and getting married and take care of his mom. So those are things that actually make a difference in a young person's life who's otherwise very productive, but blindness can rob all of his opportunities there. Now, given that you've learned a little bit about our artificial cornea program, we actually started our program here in the Pacific Northwest. And our results are actually very similar because we have a lot of collections of severe diseases. And we do that for 2 reasons. One is to fulfill the needs here. The other one also is to give us a platform to do our research. If you look at the outcomes of our data, a lot of patients actually only have light perception vision right before surgery, and they do much better after surgery. In fact, some of them achieve, as I mentioned, in the level 20/20 vision, so they can make a difference between functional and non-functional for these patients. However, the corneal transplant surgery with artificial cornea is not just the perfect picture, because it is still in its development stage, and it is a foreign body in the eye. So in the following slide, I will show you some of the catastrophic complications could occur with this, and also its dependency on medications for life. So a lot of times the skin can retract and extrude the device, can get infected. So infection could be devastating for the patient. And of course, you can see that those infection leakage really will lose the patient's opportunity to see sometimes with this condition. So obviously, this is not an ideal situation. The other thing is the cost. If you think about how much it costs for an artificial cornea, although insurance covers most of these devices, it's about $5,000 to $10,000 of a device. And for developing countries, that's really difficult to afford. With this in mind, in my laboratory, actually, we start to devise an artificial cornea that has fulfilled a lot of those needs for restoring vision as a window, because it is the window to the eye, and also to remember all the other side effects of current artificial cornea design, dependency on medication, and lack of integration into the eye, because it is still a fairly mechanical device. And how do we do that using our modern materials? And this is actually a collaboration with Dr. Buddy Ratner's lab in bioengineering, that we look at special materials that can give us the optics that can serve as a window and maintain the simplicity of surgery, so that any person who can be trained in the regular corneal transplant can do this on their own. And also there's lack of care needed for the patients who have surgery rather than depend on medications for life. With that, we actually look at some of the spherotemplated materials as based in silicone, because it gives us the early evidence of integration and also allow us to make this device in an affordable way rather than very expensive material. And these are just some evidence of in vivo models in rabbit studies to demonstrate that the materials actually start to integrate with the animal model and give us some hope that this device can be made in larger scale and fulfills that integration void that current artificial cornea still need. And lastly, when we design the cornea, we want to make sure that it can be molded, so these can be produced in large quantities to reduce the cost. So this is a cartoon showing you how these devices prototype can be made. Once you figure out the right material and the right optics, it can be made in large quantities and then be afforded by the patients around the world. This just shows you a prototype of what we have produced in the lab, demonstrating the clear optics as well as the peripheral skirt that can be used to suture onto the cornea. Next, I think I wanted to ask you to take a deep breath and imagine with me what could be next. I think is kind of cool devices and maybe opportunity to change how our view of healthcare delivery may be. This idea actually came about one of my trips to Inner Mongolia, where I noticed that a lot of our patients who came to see us on camels traveling for days, they don't have a hospital nearby, they don't even have a toilet, but all of them actually have quickly adapted a device, the cell phone. Because during that time, as nomads, they really depend on the technology as their lifeline. So that really intrigued me quite a bit. And I do think that initially gave us some ideas, how do we use wireless technology as a tool so that we can deliver healthcare in remote areas around the world. And that's where a colleague of ours is trying to look at microelectronics that we can use that's applicable for the eye. And using the wireless technology, we can gain information as well as deliver care for those who's not easily accessible to modern technology in the developed nations. So this is one of the examples. You can see that actually one of my rabbits in the lab to wear these cool contact lenses. These are microcircuitry that we're able to embed onto a contact lens shape as a proof of concept as how we can integrate these small components. And of course, if you wanted to sense materials and you wanted to test different parameters, a lot of things has to be miniaturized, and you want to make sure the power supply is sufficient. And this is just one very, very early examples of a small light. I think if you have to use your imagination a little bit, when the lights are off, you can see that small LED being turned on the contact lens. Even though this is a very weak light, I think it's great hope for us that we're able to further our goal to make sure that power is able to be generated to power other sensors. Now, in terms of transferring the information, rather than using, let's say, cell phone with a battery, it will be difficult to use that battery on the eye. So we look for RF technologies, radio frequency as a source for both transmitting the power as well as to deliver it out wirelessly. So this is one of the prototypes that was in Dr. Otis's lab in electrical engineering, that we use different materials to generate these RF coils as an antenna. And in talking about wireless technology, in the old days, we see wireless components as being huge in terms of, if you look at this old radio, these components are huge. And for cell phones right now, it's about centimeters in terms of size. And for our eye chip, it's actually measured in millimeters now. So this is actually one blueprint of our first generation eye chip that's being produced for this device. And for the next cartoon I wanted to show you is what we wanted to use that for in terms of using that in combination with our artificial cornea. So for these chips to do, they need to manage the power. They need to make sure that the data is collected and transmitted, and also these can be produced in an affordable cost. For cell phone technology, one chip right now, if it's mass produced, it's about maybe 10 cents each or so, somewhere around there. And with these different technologies, although initial cost of developing is quite expensive, but in large production, we consider that to be about around 25 cents per chip. And those are certainly can be within the range of affordability in the global market. So to put all things together, this is how we envision things will happen. So the chip and sensors are attached to the RF coil, which is the antenna. In turn, that will be embedded into the mold for the artificial cornea. And this whole device then can be transplanted to the patient who's in need. Now I can imagine my patient can transmit eye pressure or other parameters in their eye through a handheld device like the cell phone, so they can tell me, from rural China to Seattle, how they're doing. And those will probably generate different ways, I think, to deliver healthcare for the future. And these not just for the global market, for the patients who's living in the rural areas in China. And I do think that my patients living in rural Montana will still benefit from the similar technology. In closing, I'd like to share a story with you. I think actually Dr. Faggy, who gave one of his lectures in bioengineering department, he said one of his dreams is to see an African kid when he can hold a very magical device in front of his eyes and know everything about him and know how to treat and follow him. And it's still a dream. I think that to exaggerate that is not realistic, but I do think that this cover page of The Economist give us hope and dream in terms of what we could do with what our research afford us to, and maybe in 20 years, we look back, that was not, we can say to ourselves, it's not a dream after all. And finally, I'd like to thank all my collaborators. I think University of Washington is such a great environment for collaboration and to allow us to dream something that we don't have right now. And I think also our patients give us motivation and ideas to come up with better ways to treat them in order for them to see. And I do agree with Dr. Elmore that vision is a privilege, and we always appreciate what we can see. And it's those patients who can't see right now allow us to motivate ourselves to continue that research. And I hope in that short 40 minutes, I give you a glimpse of the, many of the exciting research that's been going on in our eye institute. And I hope that you'll share my dream in terms of being able to help more people to see better in the future and appreciate the beautiful world that we have. Thank you. And I'm happy to answer questions if you have some.
Yes. In the corneal transplant surgery that you showed, I have two questions.
Yes.
Most importantly, is the patient awake?
Yes.
Oh.
You can actually, as a patient, you have a choice. You want to be awake or you don't want to be awake. And I think that with local anesthetics for the corneal transplant surgeries, patients really don't feel the surgery itself. But it is more critical of a surgery that the patient is able to cooperate with me because I'm opening the eye. So if the patient is not quite sure they can do it, we put them to sleep. But a lot of times, the patient is awake, definitely.
Oh, goodness. And secondly, are the sutures absorbing or do they have to be removed? And you said
They
something
should
about
be
4
removed
years?
usually within the first year. They're not dissolvable sutures because we want their mechanical strength to keep the eye stable during the initial period of healing.
Thank you.
One more question?
Yes?
Yeah, I may have missed, this was marvelous, but I may have missed with this implant of this little chip, and you detected something is not going well with one of your patients in Mongolia. What does that then, I mean, you cannot go to Mongolia and help that person, so what do you do with that information?
Sure, that's a good question. The question is that, if you have those information in the rural areas, what do? I do feel that one is access to care, so information. If a patient has an urgent issue, how do we know they even need help? I think that's the first step. The next step, of course, will be, I envision that we have healthcare centers that's more local that can communicate with more experts around the world to treat them because they're closer to the patient. And that would be ideal situation where we can really bring state-of-the-art care to faraway areas where patients need the care. But I think, for instance, the device we're looking at right now to check the pressure in the eye might give the patient an alarm because they don't have symptoms. Talking about glaucoma, a lot of times their pressure may be a little high, but they don't have symptoms. This device might alert them to then arrange follow-up care for their eye disease. Yes.
I'm curious, for the folks you're treating in Mongolia and rural China, would you be able to, is it more cost effective to take them to larger urban areas so that you can sort of use funds that are available more effectively to help more people?
The question is whether we can treat those patients in more urban areas in those to use the funds more effectively. Then that's, I think, the current approach because you really don't have alternative to treat those patients. My goal in terms of developing our research is really to be able to deliver similar care because the technology has generated the materials, for instance, the artificial cornea model, that can be so easily used even in the local areas without the tertiary facilities. They can still be used and benefit those patients. That will be the ideal situation, of course. But for now, yeah, I think that a lot of the rural area patients will travel a long time to the urban, well, semi-urban settings to get treated. Right. That's one of the reasons why their diseases are so delayed and severe when we see them.
Thank you.
Thanks. Thank you very much.
Thank you very much.